Welcome to the Endocrine Matters podcast. This podcast episode is sponsored by Complete Medicine and Hey Healthy. Picture this, a South Asian woman, let's call her Priya because statistically someone named Priya is going to relate to this. She goes to her annual physical. She's 42, she's not overweight by any standard measure, she exercises, she eats what most people would consider a reasonable diet, she is not by any outward appearance someone who should be worrying about diabetes. Her doctor runs some labs, her fasting glucose is 101, just barely over the normal cutoff of 100. Her A1C is 5.8. The doctor looks at her results and says, "You're borderline, watch what you eat, maybe exercise a little more, and we'll check again in a year." Priya goes home. She's a little worried, but mostly reassured. She tries to eat less. She goes to the gym more. She does everything she was told. A year later, her A1C is 6.1. Now her prediabetes is worse, not better. 2 years after that, it's 6.6. Now she has type 2 diabetes, and nobody explained to her why this happened so fast, or why her weight never really changed, or why doing everything right still wasn't enough. Here's what nobody told her. Her pancreas was working against a timeline that the standard medical guidelines were never designed to catch. And her South Asian biology, her specific, particular, genetically distinct beta cell profile, meant that by the time her A1C hit 5.8, she was already significantly further along the disease progression pathway than a white woman with the same number. I'm Dr. Arti Thangudu, triple board certified endocrinologist and the physician who is going to explain to you today what Priya's doctor didn't. What is actually happening in your pancreas, why standard advice falls short for South Asian women specifically, and most importantly, what to do about it without apology and without shame. To understand why South Asian women are at such specific and underappreciated risk, I need to explain what actually causes type 2 diabetes, because most people have a very incomplete picture of this. Type 2 diabetes is fundamentally a disease of two things working against each other: insulin resistance and beta cell failure. Let me explain both. Insulin resistance means your cells stop responding to insulin the way they should. Your pancreas says, "Hey, I sent insulin, open the door to the cells, let the glucose in," and your cells basically ignore it. So your pancreas tries harder, it makes more insulin. This can go on for years without your blood sugar ever looking abnormal because your pancreas is compensating. Beta cells are the cells in your pancreas that make insulin. They are the compensation mechanism. And like many things that are working overtime for years, they eventually get tired. This is the part that is almost never explained. The race to type 2 diabetes is not just about how resistant your cells are. It is about how long your beta cells can hold on before they start to fail. And that, the beta cell reserve, is where South Asian women are starting at a structural disadvantage. Here's what the research shows, and I want you to really hear this. South Asian women do not just have more insulin resistance, they also have a genetically lower capacity to make compensatory insulin in the first place. A landmark hypothesis paper published in one of the top diabetes research journals in the world proposed that for South Asians, beta cell dysfunction may actually be the primary driver of type 2 diabetes, not insulin resistance. That is a fundamentally different disease mechanism than what we see in other populations. The Masala study confirmed this. South Asians have higher insulin resistance even at low BMI, more impairment in insulin secretion, and a specific pattern of fat deposition, more liver fat, more fat between the muscle fibers, that drives metabolic dysfunction in ways that the standard BMI number completely misses. Here's a number that should stop you in your tracks. South Asian women are 8 times more likely to have diabetes than white women at the exact same weight. That means your doctor could look at you, see a healthy number on the scale, and have no idea what's actually happening inside your body. The scale is not the whole story, and for us, it never was. And research shows that South Asian women diagnosed with gestational diabetes, diabetes during pregnancy, have significantly lower beta cell function and progress back to diabetes far faster after delivery than white women with the same history. Only 31% of South Asian women were back to normal blood sugar 17 months after a gestational diabetes pregnancy, compared to 53% of their white counterparts. There is a term we use in endocrinology called the thin fat phenotype, and yes, it means exactly what it sounds like, skinny fat. You can be the skinny one in the family, fitting into the same jeans you wore in college, getting complimented at every family gathering, while your liver is quietly storing fat, your muscles are marbled with fat, and your metabolic numbers are heading in the wrong direction. Thin on the outside, working overtime on the inside, and your BMI gives absolutely no indication that any of this is happening. You can look great on a standard physical exam and be metabolically at significant risk. And the doctor who is using BMI as a primary screen for diabetes risk is going to miss you because you don't fit the profile they were trained to look for. South Asian women are diagnosed with diabetes 5 to 10 years earlier than white women. In some California data sets, the gap is over 10 years, and the progression from prediabetes to diabetes is faster. The complications accumulate earlier, and the window for prevention is narrower than the standard guidelines account for. This is not a reason to panic. It is a reason to act earlier, more specifically, and with every tool available to you. I want to take a moment to directly address something that I hear from South Asian women patients constantly, and that I think causes enormous unnecessary guilt and self-blame. They say, I eat well, I exercise, I don't overindulge, and my blood sugar is still going up. What am I doing wrong? And my answer every time is nothing. You are doing nothing wrong. The advice you were given was incomplete. Not because your doctor is bad, but because the guidelines it came from were built on data from populations whose diabetes biology is different from yours. Here is the research. A meta-analysis of 6 randomized controlled trials of lifestyle interventions in high-risk South Asians found that diet and exercise programs did reduce diabetes incidence by about 35%. That is meaningful. Lifestyle still matters. Do not hear me saying it doesn't. But, and this is critical, those interventions produced only modest weight loss, less than a kilogram on average. And the reason lifestyle interventions work for South Asians is probably not primarily the weight loss. It's the improved insulin sensitivity and reduced liver fat. The scale barely moved, but the metabolism did. And yet most of the messaging South Asian women receive is, lose weight and this won't happen to you, which is both medically inaccurate and genuinely cruel when the woman in front of you doesn't have weight to lose and is already doing everything she was told. The ADA now recommends screening for diabetes at a BMI of 23, not 25 for Asian adults. Some research suggests the equivalent diabetes risk threshold for Asian women may be as low as a BMI of 20 compared to 25 for white women. That means there are South Asian women in this audience who are technically underweight by standard measures and are still at meaningful diabetes risk. And the standard system will not screen them, will not catch them, will tell them they are metabolically healthy. You deserve better than that. And today I want to tell you about the tools that actually address your specific biology. My clinical opinion, and I'm going to be direct. I want to step out of the neutral educational voice for a moment and tell you what I actually think, what I tell my patients, what I believe the evidence supports. South Asian women should be having conversations about GLP-1 receptor agonists, metformin, and hormone therapy earlier and more seriously than the standard of care currently prompts. Not because medication is always the answer, but because the biology is specific, the risk is real, and the window for meaningful intervention is shorter than it is for other populations. And I want to address something head-on before I go further. There is no prize for suffering through this without help. There is no award for refusing medication out of pride. There is no extra credit for managing a biological vulnerability through willpower alone. And there is absolutely nothing admirable about letting a preventable disease progress because you are too worried about what someone might think of you for taking a pill or a shot. Your health is yours. How you get there is nobody else's business. And the goal for yourself, for your kids, for the people who love you is to be healthy, full stop, whatever that takes. Tool 1, metformin, the most underutilized drug in South Asian women's health. Metformin has been used safely for over 60 years. It is one of the most studied medications of all medicine. It is cheap, generally well tolerated, and works primarily by reducing the amount of glucose your liver releases into your bloodstream overnight, which is exactly the pattern we see elevated in South Asian women with prediabetes and insulin resistance. The Diabetes Prevention Program showed that metformin reduced progression from prediabetes to diabetes by 31% in the general population. For people under 60, which is most of my South Asian patients when they're first dealing with this, metformin performed comparatively to lifestyle intervention. For a South Asian woman with prediabetes, especially one with a family history, a history of gestational diabetes, or early cardiometabolic risk markers, a conversation about metformin at the prediabetes stage is entirely clinically appropriate, not a last resort, not a failure, an early evidence-based intervention that respects the specific biology at play. If your doctor has never mentioned metformin and your A1C is between 5.7 and 6.4 and you are a South Asian, ask about it. You deserve that conversation. Tool 2, GLP-1 receptor agonists. They're not just for weight loss. GLP-1 receptor agonists are medications that mimic a hormone your gut naturally releases after eating, a hormone that tells your pancreas to release insulin, slows digestion, and signals fullness to your brain. You may know some of them by their brand names: Ozempic, Wegovy, Mounjaro, Zepbound. These medications have become culturally associated almost exclusively with weight loss, largely because of how they've been discussed in the media and on social media. And I understand why. But I want to reframe this for you as an endocrinologist who prescribes these medications clinically. GLP-1 receptor agonists have demonstrated cardiovascular risk reduction independent of weight loss. They reduce liver fat, which, as we discussed, is a specific metabolic problem driving South Asian women's diabetes risk. They reduce insulin resistance, they support beta cell function, and they do all of this in a population whose primary disease mechanism is not necessarily excess weight. For a South Asian woman with prediabetes, early type 2 diabetes, or significant cardiometabolic risk markers, even at a normal BMI, a GLP-1 receptor agonist may be clinically appropriate, or at least to have a conversation about earlier than standard guidelines typically prompt. Not because she needs to lose weight, because the biology responds to it. I'm not telling you to go demand a prescription tomorrow. I am telling you to walk into your endocrinologist's office prepared to have a real conversation about your specific risk profile and what tools match it. And if your doctor isn't familiar with the South Asian metabolic phenotype, that is information about whether you need a different doctor. Tool 3, estradiol. The conversation South Asian women are not having soon enough. We talked in episode 2 about the fact that South Asian women reach menopause earlier, on average at 48, 3 years before white women, with nearly 1 in 3 reaching it before 45. And we talked about what estrogen does to metabolic health during and after that transition: worsening insulin resistance, increasing visceral fat, driving lipid changes that may raise cardiovascular risk. What I want to add today is this. Menopausal hormone therapy, specifically estradiol, has been shown to reduce the risk of type 2 diabetes in postmenopausal women. It improves insulin sensitivity, it reduces visceral fat accumulation, it supports the metabolic health changes that otherwise accelerate after menopause. For a South Asian woman who is already at elevated diabetes risk at baseline and who is now entering a hormonal transition that accelerates that risk by 3 to 5 years earlier than her white counterparts, the case for a serious, timely conversation about hormone therapy is not just about hot flashes and sleep. While those are still important, it is about cardiometabolic disease prevention. I believe we will see more data to support this in the future. I have seen my own patients normalize their A1C on estrogen therapy without weight loss. The timing matters. The evidence strongly supports initiating hormone therapy within 10 years of menopause and before age 60, when the benefits are clearest and the risks are lowest. For South Asian women, that window opens earlier, and if you are in it, you should know about it. Again, this is not a decision to make based on what your auntie thinks or what you heard about the WHI study in 2002 or what your PCP mentioned in passing during a 15-minute visit. This is a decision to make with an endocrinologist or a Menopause Society certified practitioner who knows your specific risk profile. I want to talk about something that I see holds South Asian women back from the care they need more than almost anything else. The belief that taking medication means you failed. That if you were disciplined enough, strong enough, virtuous enough, you wouldn't need it. That medication is for people who gave up. That you should be able to manage this with diet and exercise and willpower because that's what strong women do. I need you to hear this from a physician who has watched patients progress from prediabetes to diabetes to complications because they were too ashamed to take a medication that would have changed the course of their disease. The stigma is not protecting you. It is hurting you. We do not expect people with high blood pressure to meditate it away. We do not tell people with hypothyroidism just to exercise more. We do not shame people with asthma for using an inhaler. But somehow, when it comes to metabolic disease, which has a profound genetic and biological basis, which is not a character flaw, which is not caused by laziness or poor choices, in the vast majority of cases, we have decided that medication means weakness. It does not. It means you took your health seriously. It means you used the tools that medicine has spent decades developing. It means you decided that being well for yourself and for your family was more important than performing stoicism for an audience that isn't paying your medical bills or living in your body. How you get healthy is between you, your doctor, and exactly nobody else. Across this podcast, we have talked about reference ranges that weren't built for you, a hormonal transition that arrives earlier than anyone warned you about, a stress response that is taxing your metabolism in ways that don't show up on a standard lab, and now a beta cell biology that means the standard playbook was never quite written with your body in mind. What I want you to take away from today is not fear. I want you to take clarity. You are not at higher risk because of something you did wrong. You are at higher risk because of a biology that medicine has only recently started to study specifically. And you now know more about that biology than most primary care physicians will tell you in a standard annual visit. Use that knowledge. Walk into your next appointment prepared. Ask about your specific risk profile. Ask about ethnicity-appropriate screening thresholds. Ask about the tools, metformin, GLP-1 receptor agonists, hormone therapy, and whether the conversation about any of them is appropriate for you. Demand care that is calibrated to who you actually are, not to a reference population that doesn't share your biology. And if someone in your life, a family member, a friend, a community voice, makes you feel that getting help is something to be ashamed of, let that go. Let it go completely. Your health is not a performance for their approval. It is your life, and you deserve to live it well. I'm Dr. Arti Thangudu. Follow me on Instagram at Dr. Arti Thangudu, just my name. Subscribe to Endocrine Matters wherever you listen. And if you know a South Asian woman who has been told her labs look fine and her gut is telling her something different, send her this episode. She deserves the real conversation.